While giving this presentation last year, she also learned a lot about the challenges that those in academia also faced. She believed hospital workers would benefit greatly from being made aware of those challenges as well. So, without further ado, I'm going to hand the mic over to Meredith.
Thank you. Thank you very much. Thank you guys for having me. Thank you for caring about this. Uh, it's a big gap that we're trying to overcome here. And the fact that you guys care enough to hear about it is very, very impressive. So, um, to what she had said, yeah, we're looking at three different purposes for our discussion. I'm going to review some different things that we've seen as leadership in a hospital. We're going to talk about how I've had to change my orientation and the orientation process that I had to build to support them, and then how we collaborate with our local schools to ensure that the students are set up for success when they enter the workforce. So some things to consider when we are looking at hiring. The first thing we look at is going to be resumes. We noticed of late, I think is the nicest way to say it, that there are a lot of grammatical errors, misspelling of words, incomplete histories, things that I don't know if it's they take for granted their Grammarly or whatever they're using to check their resumes, but there are a lot of missteps in the written form when you are looking at potential candidates. During COVID, we had to do virtual interviews, which had their own source of fun things that we got to deal with. They wouldn't plug in their computer, they wouldn't plug in their phone. They were dressed in hoodies, which we preferred to the shirtless versions because there were some that were not wearing shirts. And sorry, could you please put on a shirt? Things you never thought you'd have to ask. And now since COVID, we've shifted back to in-person interviews, and that, from the old adage, you dress for the job that you would like to have. They're coming in stretch pants and yoga pants, and they just don't dress the part. So that's one of the things that when you see them initially, you're like, it is a profession, right? We are respiratory therapists, but we're a professional group of people. So getting back to the business casual would be a preferred step. The canned questions that we ask, the HR canned questions, everybody knows what those are. Give me a specific example of a time when. It doesn't have to be medical in nature, but it's very easy to speak to the broad generalities. So they're not ready to have those questions thrown at them. So it extends the amount of interview time, and it kind of gets lumpy, and you're looking for something, they don't know what to give you, and then you're just like, okay, well, thanks for, we're gonna move on, Some learning opportunities from a leadership standpoint. New grads are coming out not understanding that respiratory is a 24/7, 365 position. It's nights and weekends and holidays are included in that amount of time. You're not going to walk on a day shift. That's not how hospitals operate. You're going to be on nights most all of the time. There's a very big discrepancy in the hourly or the annual salaries from what they would like and what the industry standard is. We've had people asking for the same amount as people who have been in the field for 5 and 10 years. You can't do that. That's not equitable, right? So that's been a pretty big issue here in Michigan, especially. So that's been a challenge for us. The different states that have different autonomies, right? I know in Florida they put in art lines. Michigan respiratory doesn't. And it became very apparent during the pandemic with travel therapists that certain parts of their education they took for granted, because where they were doing clinicals, they didn't do that. And then you come to Michigan, and especially in Trinity, we draw our ABGs, we run them, we interpret them, we come up with like a plan of care, and we go and discuss that with the care team. And when you have somebody who came from a different state where they've never drawn ABGs, they don't interpret them, lab does it, and then the physician calls them and says, this is the vent changes we want to make. That's a huge barrier when you're expecting them to be able to come in and do the same like quantity quality of work that you provide. So that's been something that they're like, well, I've never used it, so I never paid attention to it. I always give a pneumonia presentation at our local school, and I've always asked, I always end it with, what's the worst thing that can happen? You know, when you're working a shift, what's the worst thing that can happen? And it used to be that people would say, well, someone could die. And I'd be like, yes, yes. But then we'd discuss, witnessed arrest and what's your inpatient mortality rates and how it's low, you're going to be fine. Yes, mistakes happen. But now it has transitioned to, well, I could lose my job. And I felt very hopeless for a while. To be clear, the last year's class did not. They were back to the people could die. So I think we've made some progress. But there for a little bit, the worst thing is not that you could lose your job. The worst thing is that somebody could lose their life. And so getting back to that has been very important for us. For new graduates to just be aware of so that they are able to interview the employer as much as the employer is interviewing them. They don't know about safe staffing, with respiratory. I know different organizations are RVUs, different are workloads and different units, but ultimately, what does it mean to have safe staffing as a respiratory therapist? And leaving with 4 or 5 floors of people that you have to see, or 15 ventilators that are critical, that's not safe. And so helping them to understand that it's okay to ask those questions. Learning that a healthcare system, you're allotted the 15 minutes for a nebulizer. What needs to be done in that 15 minutes? Is it just you talking to them and giving them the treatment, or what does the full assessment look like? How to utilize that time. They don't know how to ask, like, what does comprehensive therapy mean? Like in our organization, we have a NICU, we have an adult ICU, and we have floors. We have a level 1 trauma center. And our RTs, we're not specialized. We're not big enough to be able to have specialized NICU versus adult. So you're a comprehensive therapist. And that means you have to be able to manage all of those care areas. If culture and mission and values, if that means something to the person who's interviewing, they need to ask about those. And what does your organization do to support them? How can I see them in action? They don't know how to ask about mandation requirements. We all know after going through the pandemic that sometimes that was a necessary evil in order to ensure that the patients were cared for. Depending on the organization and depending on all of the things, right? Mandation requirements are different and they can be pretty big. They can really impact your life. So if that's not something that you're able to, like, you have to come in and work Tuesday. Well, I don't have childcare. Well, you have to, you're mandated. What does that look like? So trying to arm them with information so that they're able to ask the questions to make sure that they're going into an organization that fits them best. Our organization, we like to hire students because we can quote unquote grow them, they're kind of like clay and you can shape them and you can mold them and watch them actually growing as a therapist, and their aha moments are really cool. So we really like that. As far as orientation goes, I know I'm dating myself, but I came from the see one, do one, teach one generation. You'd watch your preceptor do something, the next time you go to do it, you do it, and then ta-da, you're ready to go and teach it. That doesn't work now. This generation, maybe, these groups that are coming out, they aren't able to uptake that information. And I think it's okay because they are very tentative about making mistakes. They want to make sure they're doing it accurately. And there's a sense of ownership to that. So I had to change our orientation process to support that new way of thinking. So I created it, with Trinity being a national company. We have, we talk to RT leaders across the nation. And I kind of talked about how much orientation time do you normally allot for, your size hospital and your size hospital. And on average, it's like 4 weeks. And I got, well, we have a NICU, so it's 6 weeks. I actually built my orientation process off of nursing orientation. And so they get 6 to 8 weeks per care area. Floors and ED are together. Then after 6 months of holding that successfully, they go into another 6 or 8 weeks of orientation for ICU adult. And then they hold that for 6 months, and then they go into NICU for another 6 to 8 weeks. 8 weeks is the outside. 6 weeks, we should be able to get everything done appropriately in that amount of time. And our organization supports that because without a good foundation, they're never going to be great therapists. And so we know that it's going to take a little bit more time at the front to get more payoff at the end. The other thing about the orientation process that I created is that it's tailored to the learner. If learners are excelling at certain things, we aren't going to make you continue to do 4 more weeks of that same thing over and over. It has to be like a SMART goal, right? It's got to be timely. We've got to be able to, if we have to extend it, there has to be objectives that we're going to create and get through. It's not, I don't feel comfortable, I need another couple weeks. That's not tangible, and we can't make that operationalize that. The final thing is that failure is an option. This is healthcare. These people are running life support. There is not everybody is made to do that, right? I mean, it's a big undertaking. And so in our organization, if you are unable to triage situations, if you're unable to feel comfortable and confident running life support, then we will help you to find a different role within the organization that's going to complement your skill set. Maybe it's sleep therapy, maybe it's PFT, but we're going to help you find something that's going to align with what your current skills are. We poured a lot of time into preceptors. So I've got different things stated here about how it works for RNs. Nurse residency models provide a framework for RTs during the transition to practice. And so unknowingly, this was what I had created back in 2020 because I only had nurse leaders or nurse educators to help me build my orientation process. According to Innes and Kaya, the preceptors are a common model used within graduate programs to support transition. Preceptors are seen as a significant resource during the transition, and they provide support, knowledge, guidance, and teaching. They provide opportunities to ask questions, socialization, and clinical supervision, and increase new graduates' confidence levels, successfully helping them. So these just continue to go on about how important your preceptors are and how they are the reason why people are successful. They are a source of true north, right, for a new grad. And if you don't feel comfortable in asking somebody, you don't have the psychological safety to say, hey, I don't understand this. Can you go over it with me? Because you think that there's going to be some sort of a judgment or they're going to look down on you. You're not going to ask the questions. And if you don't ask the questions, you're going to make a mistake. So I then took our preceptors and I gave them care areas. So I have the same preceptor for main preceptor for ICU. I have a different main preceptor for NICU. I have different ED and floor preceptors so that they can really own their area. It also ensures that there's consistency in the information that's being provided. So there's not, well, Jack does it this way, but then I follow Miranda and she does it that way. I have people that do the same task in a slightly different way, and I allow them to go with a couple of different people, but it is very limited to the people that they go with, because there are right ways to do things and then there are workarounds. And we all know that. I was a preceptor for many years and I would speak to, this is the policy, but this is what we actually do. And so throughout this process, we've worked at eliminating that. We are doing what we have written down, we're communicating that, and we understand the why, right? We're all inquisitive. We all like to know the why behind things, and it helps to support following standards. If you understand where the standards come from and why you're doing it, and that's what the preceptors are able to provide. As the educator, I would meet with people every week. So every week we would do what we call the touch point. They would have the same exact breakdown every week. What went well this week? What could have gone better? We would set goals from the previous week. And so we'd look at, did we accomplish those? And then we would set goals moving forward. It's a very transparent process. And my preceptors know this, that it is, I shouldn't be the first person who's telling them something. They should hear it from their preceptors, and then I can talk to it and expand on it more, but very open and honest communication, because this is the time for you to be able to make mistakes as a new grad. We all know to err is human, right? It's going to happen. But in these moments is when we discuss that those mistakes are actually opportunities. And that's when you grow. I tell them about mistakes I've made or that their preceptors have made, different things that we've done and the outcomes, right? Um, so it's actually kind of celebrated. Hey, I heard that this was not, that didn't work as well for you. How did you change your practice? You know, how did that affect what you're going to do from here on out? It can be a really uncomfortable time because I am here to help improve people. You don't improve people by telling them, oh, you're doing a great job, even when they're not. So you'd have, I have direct conversations with people about their ability to improve. And hey, I heard that you were saying that we should give Lasix to this patient. Why were you thinking that Lasix was going to be the best option? And then sometimes they leave with, part of their goal is going to be look up Lasix, look up Ativan, look up what Ativan can do for an 80-some-year-old person with dementia. If they didn't have previous anxiety and now that's your recommendation, but they're also unable to breathe, is it more likely that they are anxious because they can't breathe? So we would talk through different scenarios. And then I would end it with a critical care sim. So either in ICU or in NICU, I would give them a patient. We'd go set up a vent. I would just run it the way that you would run a normal scenario in real life. This is your patient. This is where they came from. Here are your blood gases. And I would follow their train of thought. Sometimes, depending on where the sim would go or what the orientee was struggling with at that time, the patient would die for no fault of their own, for no management of their doing, but that's real life, right? And so to let them know you can do everything right, and sometimes it's just not enough, and the patient isn't going to make it. So then we can talk through what does that feel like when you put all of your efforts into something and you've brought in extra eyes and you've looked at it from every scenario, because that's a big loss, your first loss. I know we all remember what that was like, and we want to support you through that. So really truly growing with people and letting them know that we're there to support them. We work with our local school. We only have two here in Western Michigan. We only have two schools on this side of the state for respiratory. We work very closely with Muskegon Community College because locationally they are the closest. But we are on both of those academic boards for both programs. You need to be involved as a respiratory leadership group. You have to be involved with your schools if you want the RTs that are coming out of those schools to be prepared to work in your organization. I know that they'll tap into me like, hey, what AEDs do you guys have? Here's a fitting. Can you see if this, CO2 monitor and end-tidal CO2 fits your life pack? Because they want to have things that are as realistic to what the students are going to see when they come into the hospital. And so it makes a really cohesive working environment when you can go back and forth with them and you can tap into them and say, hey, what are you teaching people about vent circuit changes on adult patients? They don't teach that anymore because they're asking us, what are your average vent days? And we're like 2.75. Well, there's no point, so we're able to from both sides kind of shore up what it is that we're doing and teach what it is that is actually being utilized.
Hey, Meredith, an
Yeah,
interesting question just came in.
yeah.
Have you utilized an internship program for your new grads that you have hired?
So we have, they're called respiratory care assistants or RCAs, and they are students. We hire them when they're students, and they help primarily with equipment processing, ordering, stocking. They come down to codes. So yes, but we can't call it an internship because it's a paid position and they're a part of our team. But yes, for those students who we have or anybody that is in a respiratory program, so that's one of the requirements of it, you have to be in a program. We hire you and you're a part of our team. So you come to the team meetings, you go to codes, You can wander around with therapists if there's not equipment to do or things, supplies that need to be ordered. They are an integral part to how we operate. It frees up RTs to do more therapy. So they are amazing. We love having them.
Perfect. Great. Thank you.
Yeah. So the other thing that works really well with having students, we are not an organization where we have those therapists that, oh, well, that therapist just can't take students. We don't do that. Everybody is expected to be able to have students, to treat them with respect and kindness and be willing to show them how to be a therapist. So, when I was going through school, there were times I would end up at a hospital and they're like, oh, you can't go with that. They aren't allowed to take students. That's not what we do. The students are our future. So you have to be willing to support the future, or you're just going to suffer alone because there's going to be nobody else to help you out. So everybody takes students. If there are issues with either a student or an RT, I will get specifics. I will send those to the school, and vice versa. The school will send me specifics on different RTs, and we will sit down, we hold them accountable. What was going on that day? Why would you say something, like, you don't need to come, there's nothing for you to be able to do, just sit here, finish your homework. The snide comments that sometimes can be made. And we're going to talk through what was going on that day. That's not normally how you act, or what was going on that made you act that way. And then they'll apologize, which is the really cool thing, is that because they're people too, right? And so our RTs will actually have conversations with students. Hey, I'm really sorry about that. I was just having an off day. It's also been really cool for me to tap into different students because they go with different RTs all the time. So I can keep a pulse on practice variation throughout our team. The example that I always come back to is art line draws. So we do draw art lines in West Michigan. We draw our samples for ABGs, and we have the VAMs. And different students were with different RTs, and there's a set amount. You have to draw back those 12 cc's, right? That's manufacturer guidelines. That's what you have to do in order to clear the line. And from our old waste system, some things had been brought through that people were only drawing back 5, or they were only drawing back 10. And the students came to me and asked, they're like, how does this work? Because I've seen it done different ways. I did like a quick survey of the team, different members, and was like, how do you draw for this? Turns out there was so much variation and it wasn't being done appropriately. So I was able to re-educate to that and explain the importance. And, it was great because the students were brought in, they were part of the solution. And I mean, they thought they were in trouble when I'm like, hey, let me talk to you for a minute. But then they realized, no, they were part of the solution. And it was really cool to be able to say, hey, the students brought this up. They are here to help. And it's been a really great unification between our local school and our hospital. Something that I've learned from the schools, that I like the schools to come in and talk to the staff as well, is that there are a lot of things that happen from a school standpoint that bedside therapists and even and leadership, we know nothing about. When I did this the last time, I learned about rates of attrition for colleges and universities, and how, if a student isn't meeting the grade and isn't doing, maybe they don't want to be at clinicals, or they're like, I've seen that done once, I'm just going to stay here in the department. That disinterest is communicated to me. It'll be communicated to the school, but then that same student keeps coming back. And I think bedside therapists think that the schools should just be able to eliminate them, get them out of the program. Well, you can't. And so explaining some of those difficulties and problems with recruiting new students and keeping new students, and the financial burdens from a school standpoint that go into that are massive. And I don't know the extent of that. I'm not even going to try and explain that I do, but it's a lot. And so trying to just ensure that the team knows that there are things in the academic world that we don't know, but you can't be so quick to just cut ties. That's not how that works, And again, back to, you have to feel safe to make mistakes, and you have to know that from those mistakes, you're going to learn. That's a part of it too. So that is all I have.
Get back to unmuting myself. So I'm going to we're going to open up for questions, but I do have another one for you. Do you have a guideline for students who come to your facility for clinicals?
No, nope. It'd be a good idea, but no, we don't. It's hard enough to try and keep up with policy tech and keeping hospital policies up to date, let alone writing one for students. It's more the unwritten. You have to take the students. You're not going to be banned from students, and explaining the why. You know, they are our future. If we don't help them be successful, we will not be around. So it's a great idea, and we should definitely write one.
Right? So I really want to commend Meredith for bringing such an important perspective to the conversation. Her focus is on preparing new graduates to cope with patient death and equipping them with the mental health tools that they need. This is both timely and essential for sure. It is a reminder that while clinical skills are critical, emotional resilience is just as vital in our profession. So,
Absolutely.
right. So I see Amanda Pereira has her hand raised. So can we unmute Amanda and have her
Sorry,
ask her question?
I didn't mean to have my hand raised.
Oh, okay, there you go. Okay. So I have another question. Do you utilize behavioral questioning in your interviewing process?
Yes, that's a part of the HR canned questions. They're the give me a time when you had to educate a patient, a family, or a staff member to do something that they didn't want to do. How did you do that? What tools did you use? Those sorts of questions. We try and make it more relatable to respiratory. But having any sort of conversations like that, how do you handle these times? How do you handle conflict? Um, you, there are very differing answers we've gotten from those, and it does kind of highlight the true colors that people will bring to the table.
So, yeah, that is so true. People come up with some good responses to that question, don't they?
Yes, they do.
So I do remember you saying that everybody is a preceptor. So you have that stance where everybody, must, and it's pretty much the same way here, but we both know that there's some preceptors that are, just a little bit better than others. So do you have your staff take the AARC clinical preceptor program course? Where are
They
they getting their education?
So Trinity Health has a preceptor. They have a progression through HealthStream. So they take that. They are assigned that. So everybody has to take students. Not everybody is a preceptor. And so the preceptors have to go through those health streams, those mandatory interactive health streams, and they cover, not everybody learns the same. So keeping in mind that there are differences to how you might have to verbalize something, or more people are hands-on, right? We're all respiratory therapists. Most of us are very hands-on, but you might have to change the way that you're saying things. So it helps to open up to the preceptor, like you might have to spin how you do things. You might have to use more drawing here. You might have to focus more on waveforms here.
Right.
But it also helps to explain the importance of a preceptor and really empower them with the fact that you're not just teaching them the job. You're a coach, you're a mentor, you are somebody who is their true north when they need help. They're always going to come back to you because you help to make them who they are. So really owning that process the other thing, I've talked to the preceptors a lot of times, and like I said, I precepted for many years before I became the educator. And to have somebody with you every day that you work is exhausting. So I would kind of protect the preceptors. I would not schedule orientation on weekends to kind of give them their weekends to themselves, and also weekends or holidays, because I feel like I should be there. And right, as an educator, you're generally a Monday to Friday. They would still call that, and that's fine. Like that's the relationship that I had with the team. But it should be when I'm available. If there's anything that has happened, anything that goes wrong, and it has, right? And they call and I go running, because there are some things that you just can't have happen on orientation or really in a hospital. Uh, so that's when you, like, as the educator, you need to be able to be that leader and say, okay, we're going to take a step back. Let's talk through this moment in time when it's happening, not in 3 days when it's a Monday again, you know?
Right, right. I do remember you saying that you differentiate your orientation between critical care versus med surge, that you put your new hires through certain rotations with I'm going to assume they're clinical specialists in each one of those areas.
Correct. Yep.
Yeah, that's pretty similar to what we do here. Have you been seeing that new graduates aren't clear about the differences between having credentials and licensure, and that there's different requirements for each?
Yes. That is
How?
a real source of confusion. Um, be, and to try and explain the difference, and you're like, well, you go to, for us in Michigan, you're going to Lara, right, for your licensing, and you're going to the MBRC for your credentialing, just the different areas that you have to go to. And sometimes it's still, people are like, what do I think we had one guy who got his license and didn't realize he had to get it again. So it lapsed, and everybody's talking about, man, I gotta pay for my license. And he goes, what are you talking about? I just had to pay for it the one time. And we're like, what are you talking about? So it does, that causes a big source of confusion.
So I'm going through I mean, the questions are coming in just as fast as I can ask them to you. So, what is the retention rate for your new grads? There's a couple of questions regarding that. And is there a difference between student hire and seasoned hire? So I'm assuming
Yeah.
that's in relation to the orientation process, because even though you have a student, right, it's a new grad. When you get a
Mhm.
seasoned therapist, they may have experience, but it's experience from another hospital.
Yes. So I'll answer that one, and then I'll go back to the retention one.
Sure.
Um, when I said that the orientation process is built around the orientee, that's exactly what I mean. For somebody with experience, we're going to set them on a 6-week path for a care area. However, if they're like, I've got this, and I'm talking to the preceptors and they've got this, and I talk to the nurses that they've been working with and the physicians, and they're like, yeah, they work really well with us. Because that's the other thing too, you're a part of a team. And if you can't work well with a team, Trinity Health is very team oriented.
Right.
I have my role, the nurse has theirs, the doctor has theirs, and we come together to do what's best for the patient. And so if you do everything right by the competencies and by an RT standpoint, but you can't communicate well with the team, then you're not meeting the progression guide that I have. And so we're going to go ahead and we're going to pump the brakes, and we're going to talk about that. But we do, yeah, if you're meeting all the standards, if you've got a week left and you're like, everything's filled out in your book, everything is signed and appropriate, do you want to come off? Do you want to still work these days? Are you willing to be flexible and move to some of the open shifts? Yeah, we will change. It is it's a little bit, it's not so much learning the basics, right, that you're going to have when you hire a new grad. It's learning, the Trinity way or your hospital way, right? So
Right.
that is one thing. The retention. So in West Michigan, Trinity has competing hospitals that are very near us that offer gigantic sign-on bonuses. Just giant. 25,000, I think, is what it's up to at this moment. So we don't have a lot of students that come and work with us that don't actually want to work with us. They're usually students, they've seen the orientation process. They're like, I want you to be my educator. I want you to build me into the RT that you know I can be. So they want to be there and they want to learn and grow. It doesn't mean they're going to stay there forever. However, most of them have been there for a very long time now. But that huge bonus from the other hospitals helps to weed out the people that would potentially leave anyways. But it also makes it so that we only get one or two new hires a year.
Wow. Wow. I have a question here that wanted to know if you provide all your didactic teaching on day shift or once they go to nights, and day shift, night shift is a little bit different. So do they get an additional bit of orientation once they go to night shift?
Yep, generally I do a 4 week on days, 2 week on nights. So you're going to have most all of your competencies and the didactic portions completed on day shift before you go to nights, but then appreciating the fact nights has a completely different flow. I was a flex RT for the first 7 years of my career because there weren't day shifts available. So I did both shifts. And it was always fun to be able to, you're sitting with day shift and they're like, well, night shift doesn't do this. And you're like, how do you know? Because 3 days ago when I worked, they were doing that. And vice versa. Like, so it was kind of fun to be able to flex that muscle every now and again and be like, no, that's not what happens. But it is a different flow. And, grand rounds is at different times on nights. It's not as structured. It's more like, hey, let's do them now. And you're still scrambling to see all your people. So they do get more of the didactic to that point is, yes, done on day shift. More of the competencies are completed on day shift. You have passed the sim that I put them through before you go to nights. But I do appreciate the fact that it is a completely different
Oh
beast in
yeah.
its own self
Oh yeah.
and get them the time.
I just want to remind everybody as we're going through these questions and Meredith is answering them all so graciously that there's a lot of people, Meredith, that are requesting information from you about sharing your plans and any of the materials that you mentioned. And all of that will be placed in the Leadership Grand Rounds Connect community. It'll be in the library in about a week. And any materials or anything, you can connect with Meredith directly through AARC Connect and get any of those things. There's another question here that says, after an employee completes orientation, what does your follow-up with them look like? Do you do like the 3 months, 6 months, 9 months, or weeks, or how does your
Yep.
follow-up look like?
So I do a 30 day and then 60 day, and then my manager and I would meet with them at 90 days, um, just to check in. Just, hey, how's it going? How are you feeling? How are things working? I'd also check in with like the charges on their shifts, whatever shifts they're working. Like, are you having to help them more than you would normally have anticipated? Are they calling you for absolutely everything? Are they never calling? Because if a new grad is never calling, that's also slightly concerning because you probably should occasionally have a phone call. And so just kind of getting the vibe from everybody. They know, ask me questions whenever you have them. They'd email me, sometimes haiku, because that's our secured chat if it was patient specific. But yes, we do a meeting and I would assess with the team as well to see and make sure that they're doing all right. And then my manager would meet with them and then kind of like sign off on, okay, now you've got another, 3 months that you're going to hold this before we go to the next care area.
And I see we have a Bill Gilmer is asking, he said he does whoa, where'd he go? Another question came in. He does an RN/NRT internship program, and he's asking if you could share your program. So again, Bill, I'm going to say that if you want to connect with Meredith directly through Connect, I'm sure she'd be willing to share anything with you.
Yeah.
Um, So I have another question that says, how do you customize orientation strategies for incoming therapists at different skill levels while still trying to maintain consistency and your standards for orientation?
I always start at the same place. I always start with the basics. Everybody starts with floors and ED, regardless of their skill level and where they're coming from. In that round of orientation, you're getting a lot of the organizational specialties. How to punch in, how to punch out, what does the VO process look like, or the IVO process. Um, they are, kind of sheltered for 6 months when they're hired. They're not called off if there is staffing ability to do that because they need to work and they need to be utilizing what we teach them. But everybody starts at the beginning. And if they're like, oh, well, you guys use Kronos, I've used Kronos forever, or you use Epic, I've used Epic. Our Epic is different.
Right.
There are many different platforms of Epic. Ours is not, well, it's arguably not the best one. So some of the things that you are able to do at a different organization's Epic, we can't do here. But if they're whizzing through some of those things, because yeah, they've used it before, they've done it before. Oh, you have MetaNeb here. I've never used that. So I'm going to focus more time on that. But your Cough Assist, I've used that plenty of time. Those are the things. That's where you can kind of progress them quicker. But they all start with, and they all have to complete the same. I always say it's the largest paperwork orientation place that you're going to go through because that's all the general stuff. So they all start at the same spot.
Right. It's this kind of ties into what you were just talking about, and I think you mentioned it a little bit, but I know we do this here as well because there's just so much to it because we're such a big organization, Henry Ford.
Oh
But
yeah.
this question says, do your students or staff receive orientation that includes HR policies? And that's a big one, I think, clocking in and time
Yep.
off and all of those types of things.
So nursing orientation, for some reason it's still called nursing orientation, but everybody does. So I want to say it's a 2 hour, you have to sit at a computer and be involved, interactive type of and I don't even know, it's a lot. And so it does cover that. But then they also get like 1.5 million health streams that they have to get done within the first 6 months of hire. And so a lot of that covers those time and attendance policies. My manager will meet with them also and discuss those things that are specific to respiratory. But yes, all of the organizational stuff is covered when they're hired into the organization.
Great. Um, I have a little message here. It says our AARC Leadership Grand Rounds team is interested in hearing from all of you out there regarding topics and speakers for 2026. As we've done in the first 4 years, we'll create the 2026 schedule based on feedback from all of our attendees. You can email them to gwkaufman@hotmail.com or connect with Gary directly through AARC Connect. And what about any tips for oh, this is a really good one. This is a struggle for me. Any tips for orienting new grads that are hired PRN? So you have those contingent therapists that are coming in, not doing those, procedures as often as others, tend to forget things because you see them one week and then you don't see them for a little while. So how do you handle that?
It's going to sound really bad, but by and large, we don't hire new grad PRN. We've tried it a couple of times and their focus is pulled to their full-time job. They don't have a good base or a good foundation to be able to support in a pick up and go PRN manner, right? You can't, as an organization, you can't operationalize putting as much time and effort into fully growing a PRN therapist. And since they're new, they don't have a foundation to start from. So the few times that we have tried it, it didn't work out well. So for the most part, and especially again with our kind of climate around Michigan, they're not actually looking for PRN jobs so much right now. We have a very limited PRN pool because you can pick up extra time at your current job and make a ton more. Again, the days of old were different, man. I had to have work at two different places to pick up
Right.
overtime. Not anymore.
Right. Just curious, I know we're talking about the new graduates and everything, but how do you address continuing education and keeping your staff motivated regarding keeping up with research and where things are going in the field, even though they may have been working for you, 2 years, 5 years, 10 years. You can't stop educating the therapist, but it seems like the longer they work, not all, but some just aren't as motivated as the newer grads tend to be.
That is that is a great question because that is legit a problem. Um, what I started doing last year or 2 years ago, I started what we term the education corner. And so I would take current policies, current things that we utilize, kind of like the high risk, low frequency, or the high frequency and never really done appropriately type things. And I would create education and put it up in the education corner and I'd leave it up for a month. So every year we're reviewing a current process, but it was from what their asks were. What are some things that you're unclear of? What are some things you'd like to learn about? That's something that our manager she's really great about doing. She doesn't lead, she supports. And so what the team wants to do, right, you're always going to get more buy-in if it's something that they believe in, they've come up with, they've put work in. So what do you need from us to support you in being successful? And we're going to do that. So that's the other thing that we've always done. Tell me what you want to learn about. I'll put something together for us. You and I can work together on it. But the education corner helped a lot because people would read it and be like, I completely forgot that when I'm setting up a hood in NICU, that's what I should do for the heat temp, what's that heater.
Right.
So just that was helpful as well. But it is a problem because some people they're here for 12 hours and that's it. And they want to go home. They do
Oh,
their time during the week
exactly.
and then they leave. So you've got some of those.
Do you do an annual skills fair or anything like that? There's annual competencies that you run everybody through.
Yep, I do
Um,
a needs assessment and ask what they want to learn about, things that they either themselves struggle with, they've seen other people struggle. We always focus on those high risk, low frequency items. I do skills fairs like in person so that's one of the questions, like, do you think you want a skills fair this year? And they wanted one 4 years ago, and then the next couple of years they didn't want one, and then this year they wanted one again. So we do 4 hours and you come in and there are different stations and I create quizzes. This year I created quizzes like through forms, which was really cool. Take the quiz ahead of time with questions. Because this one we call the Back to Basics Skills Fair, just reviewing some of the standards, some of the basic things. And the point of it is for them to learn. So take the quiz and then you do the station and then you take that exact same quiz again. And the hope is that you're going to get a higher score, but if not, it gives you the answers. And then also you can, in 6 months, you can give the same quiz again just to spot check, where are we at? Is there drift? Are people still remembering how to avoid a VAE? Those sorts of things.
right. So it sounds like you're really allowing time for this education, as I know there's a lot of leaders out there that have clinical educators, but their hands are a little bit tied with administration where there isn't any true dedicated educational time for these things to happen.
Mhm.
It sounds like where you're at, you are a little bit more liberal and you are allowed that time, which is great. What
Yeah.
would you suggest for those leaders that aren't as lucky as we are having this allotted time for education?
That's really hard. And I'm not quite sure. I was at Trinity Health Grand Rapids as an educator, and I still do help with different things right now because I just transitioned to the safety specialist role 2 months ago. The new organization that I'm at in Trinity Muskegon, they have different issues with being able to mandate. Um, so still working through that. If anybody has any good ideas, please let me know.
right?
That's a tough
It
one.
is so true. It is so true. Does anybody else have any questions out there? I've been going through this chat. They were coming through fast and furious, let me tell you. Making sure I didn't miss anyone because we still have a few more minutes left. Just making sure. No, I got them all. Another interesting thing, I just got back from AARC Summer Forum, and there was a lot of discussion regarding the use of AI. And I was just wondering what your thoughts were and if you incorporate any artificial intelligence into your educational sessions or anything that you're doing, even updating policies or any of the competencies that you're using with your new hires.
I don't know that much about AI myself. I always tell people I'm like an 87-year-old in a younger person's body when it comes to technology. I am trying to learn it. I recently heard a quote that says, "You will not lose your job to AI. You will lose your job to somebody who knows how to use AI." So I am working on learning how to use it. I do not currently know how to use it well.
So I just got another message that said many of the attendees are wanting to connect with you. And I did, suggest that they get to contact you through AARC Connect. But would you mind if I put your email address in the chat for
Yeah,
people? Would that be okay?
yeah, that'd be great.
Would you prefer a different email address from the Gmail, or is that one okay?
You could use my professional one.
Okay, and that
That's the Trinity Health one.
boop, ta 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 ta. Let me see where that is. Okay, so that is KRIGERM
Hmm.
at Trinity with a little hyphen there, health.org.
Yeah,
There you go. I think I did that right. When I have to type fast on the fly, I don't always do such a great job.
yeah, I struggle with that too,
Yeah.
especially if I think people are watching. I make so many mistakes when I think people are watching me type.
Right? Well, it is 2:56, and I did want to make sure that I included a big thank you to you for such an interactive and informative talk. I know there was a lot of buzz at Summer Forum about education and new hires and all of these things. So this is really a timely talk. I also want to give a big shout out and thank you to the AARC for supplying us with this platform that allows us to provide these educational sessions for everyone. It's not just leaders, it's educators, it's everybody. So bring your friends. There's lots to learn from Leadership Grand Rounds. And please join us all on August 21st at 1 o'clock Central Time, 2 o'clock Eastern for us Michiganders, right, Meredith?
Yes, goodness,
Um,
that's a
the
rough one.
next Leadership Grand Rounds is everything RT leaders need to know about transport. And that talk is going to be given by Jen Watts. And let me see, any more hands, any more questions? No, I think we got everything. I think we're in there. So if anybody has anything in the last 3 minutes here, I think we are good. So I want to thank you again, Meredith, and trust me, I'm going to be picking your brain myself. So
Thank you for this opportunity. It's been really great. I appreciate it.
okay, you're welcome. And we'll see you all for the next Leadership Grand Rounds. Again, that is on August the 21st at 1 o'clock. Just to review, it's going to be everything RT leaders need to know about transport, given by Jen Watts. Thanks again, Meredith, and have a wonderful rest of the weekend.